Maylin Brewal. I am one of the wound asthma incontinence nurse here in Kaiser LAMC inpatient. I am here today to present to you the topic about investing on pressure injury prevention. In the picture, you can see the Pressure Injury Prevention Committee. So the presentation agenda focus on attending to braid and subscore, especially moisture. If you remember before, our parameter for pressure injury prevention was based on the total braiding scale. So we want to use a different approach now. We want to focus now on the braiding subscore. And for this presentation, I hope that at the end, you would be able to be knowledgeable on what to use in case your patient has moisture problem. Follow up on patients identified as a skin watch list. This is also one of the update that we have on pressure injury prevention. You can refer to your assignment every day, to patient assignment every day if you're patient on a skin watch list. Our goal is to avoid reportable pressure injury. As we know, the reportable pressure injuries are those hospital and community-acquired pressure injury that turned into a stage 3, stage 4, and unstageable pressure injuries. These are who are the skin watch list. These are the patients who are moderate to high priority watchers. They are the nurses need to observe the skin bundle and the treatment compliance every shift. And we should be able, especially the skin champion and the ADA, should know how to use the standard patient rounding tool for skin. There is a schedule for skin safety drill on every unit, usually every week. Another goal is for ongoing pressure injury prevention awareness and validating staff knowledge. The frequency is at least once a week, and it can be more depending on unit's happy incidents. And another intervention that we are planning to do this year is introducing the microturning in critical care. Top 2 skin areas of risk are buttocks and heel. They are at-risk skin areas for bedridden patients. So what are our interventions? Is to remind nurses to use moisture barrier for incontinence care, to elevate heels with a floating device or pillows, in addition to patient repositioning, turning. And if you can please check, the specialty mattress are turned on to correct microclimate imbalance. So this is an example of a skin that is too moist in the gluteal fold. And this is an example of a skin that is too dry on the heels. LMC nurses will focus on attending to low-braided subscale with appropriate intervention. Just like what I said earlier, all of the patients with subscale of 2 or below should have an intervention. In this slide, you will see that, for example, if your patient's activity is 2 or less, which means that they are bed fast or chair fast, with a level of function of 1 to 3, you should turn your patient every 2 hours. You should use wedges for 100 pounds and more. And you can use pillows if the patient's weight is less than 140 pounds. For sensory perception of less than or equal to 2. So that is a descriptor, is if you can feel, if your patient, or I mean, can your patient feel or report discomfort related to pressure from position and devices? Can my patient report when they are wet soiled? Can my patient tell if the sheets are wrinkled underneath or under the tubing or resting on skin? And with that, you have to document that you applied your Mepilex border. So what we're trying to emphasize here is we want to make sure that if your patient has a braiding subscale of 2 and below, you should have an intervention. You should intervention, and how do we see it is on your documentation. Another example is for your shear and friction. If it's less than 2 or below, So you should use your air taps. You should use your Repo sheet. You should use your Swin 24 moisturizing cream for your patient's dry skin. For mobility up to and below, for heels, you should use your TrueView boots, and you should offload your patient's heel with one pillow for each leg. And then for moisture, if their braided subscale is 3 or below, then please refer to your guide on how to use our available moisture barrier cream. And for nutrition, if the subscale is 2 and below, you should consult our nutritionist so they can see our patients to check if they have a special need when it comes to their diet. So here's a scenario. Mrs. Austin is a 63-year-old obese female admitted for acute ischemic stroke secondary to long-standing hypertension, DM, and history of MI. Upon initial assessment, admitting nurse assessed that she is incontinent to urine. Her perineum and sacrum are excoriated. As a primary RN, what are some of our practice expectations in relation to appropriate skin management for Mrs. Austin? Of course, it's important that we do the 2RN skin check. Expose skin, remove devices, and if the patient has a lot of white-colored barrier creams, lather skin with sudsing easy clean wipes, gently pat dry, avoid use of washcloth. And then you have to document the assessment of problem skin. Where do you recommend your 2RN skin check? It's under the integumentary section of your flow sheet, and use a comment that you check the patient's skin with another nurse. For braidiness assessment, please don't copy and paste. Please make sure that you are assessing your patient's braidiness scale assessment because your intervention will depend on the accurate braidiness subscale. So if moisture control device have been applied on patient, moisture score of less than 3. And then you should initiate your wound flow sheet, moisture associated skin damage. And you have to document what kind of barrier cream that you use to protect skin from moisture. So what I want to emphasize in this slide is since we're trying to reinforce the management of moisture, when a patient's braided subscale again is 3 and below, you should have an input on your intervention on what kind of barrier you use for patient's incontinence. Or if the patient is sweaty, then you should also document what kind of intervention you need, like changing pads or keeping them dry all the time. These are the products that we have in our medical center for moisture management. So as you can see here, for hygiene and skincare, we have the Easy Cleanse system. It's important that I mention to you to wet only needed wipes with water, and it's also compatible with liquid CHG. So why we wet only needed wipes with water is because of the reason for bacterial colonization when you keep those wet wipes in the sink and use it later on. We also have the Sage G wipes for surgical and patients with central lines and indwelling catheters. For dry skin, please take note that Swin 24 once a day moisturizing cream is not really a moisture barrier, but it's actually a moisturizer for your patient's dry skin. So please don't use this as a moisture barrier for incontinent patients, but rather use it for dry skin to protect them from damage. Incontinence pads, use only one under patient. Please don't do linen burrito. And use your interdry under the folds wherein patient can trap moisture and also can have break under skin. Example are their abdominal folds and the breast folds. And please also special mention for interdry, you cannot use it with another product like nystatin powder. Use interdry only and not in combination with paste, with cream, and other products. We also have the condom catheter, of course, for male patients with urine incontinence, the quick change wrap, the Hollister male urinary pouch, the Hollister soft flex for fecal containment. We have the Pure Week for female with urine incontinence. Please don't use it for male patients. And then we have our FlexiCell as fecal containment device. Caution, special mention for FlexiCell, do not overinflate balloon and do not use over 28 days and reposition the rectal tube every 2 hours. For barrier creams, these are the examples, these are the pictures of the skin breakdown that you can use each specific product. So for example, for Purple Top, this is being used for mild to moderate skin irritation like redness. Black Top is for severe skin damage, like if you already see open areas, then you should consider using the Black Top. If skin begins to open, consult inpatient wound therapy. A special mention for Black Top, I know that a lot of the nurses like to remove the paste all the way to the skin level. To remove the paste for reevaluation, you can use the SUD-C Easy Cleanse Wipe. You can try it next time when you take care of a patient using black paste. Make your Easy Cleanse Wipe really SUD-C and use to clean or remove paste, and you will find that you can easily remove it. The green top is for patients with damage or satellite lesions, just like in the picture. This patient, aside from the fact that he has moisture-associated damage, which is just redness, you can see in the picture that patient also has some satellite rashes. So that means that patient has a fungal dermatitis and the green top has miconazole on it, addressing that problem. So again, for incontinence care, we want to emphasize again that for moisture subscale of 3 and below, we are expecting intervention from you. For example, in this algorithm, you will see that if your patient has urine or feces incontinence episode, and if they have an intact skin, then you can use either Mepilex border or the Criticate Clear for prevention. If your patient's having diarrhea and you keep on changing your Mepilex border more than once a shift, that means that it's not for them. You should start using just the moisture barrier and hold your Mepilex border sacrum. Another special mention is when you're using your Mepilex border sacrum is to label it with P, which means prevention, the date, time, and initial. And for treatment, you have to put letter T. What's the difference is if there's a label, if you see P on your Mepilex border sacrum, that means that you need to peel and peek. If you see a T, that means treatment. You're not supposed to bother the wound healing process, so just leave the dressing alone. And then you can just document on your flow sheet that the dressing is clean and intact. Okay, so if your patient's an inflamed, red, broken skin, and as a baseline, if it's no, then new worsening inflamed skin deterioration from baseline, NA to inform primary RN to take picture, update picture, and KP Health Connect, and inform ADA charge nurse, and WCN consult if appropriate. If that is their baseline, lather Easy Cleanse bath wipes, gently wipe up soiled area, and then apply your black top for treatment. And please just apply it in a thin layer and do not scrub skin to remove paste. So again, our nursing intervention for moisture problem or like we call it also incontinence-associated dermatitis. Apply moisture barrier, use Purple Top, Criticate Clear. That is if your patient's skin is only mildly irritated. For women, manage urinary incontinence with the use of Pure Wick device. Ensure that patient is on a low airless mattress. Add air pump if patient is an isoflex mattress. Limit linen to 2 or less than 3 layers. Reposition at least every 2 hours. Use wedges if weight is greater than 150 pounds. Mepalex to protect sacrum. Avoid shearing force while in bed. Use waffle cushion if sitting on chair. And may add to unit skin watch list. You have to inform your charge or ADA. Share reason in team communication since patient may not have performed wound care order. Shift to shift expectation, 2RN skin check, and skin bundle compliance. So this is a reminder for our nurses. This is called the Pressure Injury Discovery Checklist. This is your guide whenever you see a pressure injury, whether it's community acquired or hospital acquired. This is available on your binder. There's a binder in your unit that is specific for pressure injury prevention and treatment. But just to give you an idea on the content of this pressure injury discovery checklist and what you're supposed to do whenever you have a HAPI or CAPI, first is determine if it's community acquired or hospital acquired. So again, hospital acquired is a pressure injury that is discovered 24 hours after admission. And then you need to initiate the flow sheet and document the following: location, stage, measurement, the peri-wound skin, the drainage and exudate, the odor, and the presence of undermining and tunneling. Okay, so the treat, we have a wound treatment dressing guideline that's also available while you are waiting for the wound care nurse to come if it is an appropriate consult. So follow the perform wound care order in KP Health Connect. Consult wound care for all HAPIs, multiple stage 2 DTPI, unstageable stage 3, and CAPI. Also, we want to document the order for inpatient wound therapy consult. You have to order inpatient wound therapy consult, order inpatient nutrition service consult. You have to take a photo of the pressure injury. You have to notify doctor and confirm documentation in Health Connect. Please do not own the pressure injury. You have to share it with the physician, and they should be aware that the patient has an existing pressure injury. And they should document it also on their note as part of the patient's problem. Notify DA and ADA for HAPIs only. Complete with Health Connect wound flow. Complete your Health Connect wound flow sheet. The wound care nurses are not responsible for the wound flow sheet, so make sure that if you need to change the information in your flow sheet after the wound care nurse see the patient, please make sure that you make an edit to your wound flow sheet. So shift assessment, doc flow sheet is in the integumentary section. Initiate one wound doc flow sheet. Multiple pressure injury must be documented individually. Complete TOR for any HAPI and HAPI copy deterioration. Initiate pressure injury care plan in patient education. And if patient is refusing pressure injury prevention measures, initiate non-alliance care plan. Steps under wound progression. So let's say your patient was admitted with stage 2 and now a stage 3. So take photo as required, consult wound care, and then initiate suspected PI flow sheet, stage DTPI, continue moisture management plus anticipate treatment. I would like to also inform all of you that not all pressure injuries need to be consulted to wound care nurses. So we have skin champions and wound treatment associate as your resource people in your unit, and you can ask them about the treatment, and you can ask them information about pressure injuries, like how to manage or what are the things that needs to be done. So pressure injury prevention intervention addressing low Braden scores, like Braden score of 14 and below, need not to be consulted. simple happy CAPI stage 1 and 2, moisture-associated skin damage, and skin tear. I would like to correct here that happy, regardless of stage, needs to be consulted to wound care nurses for confirmation. Consult CWON for any suspect. That's us. Any suspected happy identified, nurse leader to complete UOR for confirmed happy. Any CAPI multiple stage 2, 3, 4, DTPI, and unstageable PI. Wound deterioration, happy CAPI stage 1, 2, DTPI to stage 3, new ostomy, fistula, peristomal complication, and complex wound. You don't need to consult a wound care nurse if patient is CMO. And consult physician for patients who may be in skin failure. You gotta ask them if the patient needs to be consulted. And rashes, please contact physician because we have limited knowledge on skin lesions or rashes. These are more like dermatological lesions. So let's heal the hospital-acquired pressure injury. So our goal is to prevent our hospital-acquired pressure injury from deteriorating. So what should we do? If confirmed deep tissue pressure injury, complete the UOR. Inform, charge RN or skin champion to assist. Formal happy notification will be sent to nurse leader. CWON will pull patient to wound care list to wound care skin watch list, which is the high priority to prevent reportable PI. List is announced in daily huddle. Include skin watch list patient on daily assignment sheet. Unit leaders to use rounding tool, emphasizing skin bundle compliance. Orients new staff assigned to patient. A skin champion can assist with root cause analysis completion. You're probably familiar with this product that showing in the slides. These are the common product for wound treatment. And please document use of products as prescribed on wound care flow sheet. So where to find them? If you can't find what to do with the wound, you just look for or search for perform wound care order. The Triad, the VASH, and the MediHoney are all available from our material management now, extension 8140. And then the Venelex ointment, Santil, Solvadine, available in the pharmacy. If you need a wound vac, the wound vac is available at wound care nurse's room. If it's after hours, you can ask the house supervisor to open a room so you can get the machine and then leave us a message on the patient information who used the wound vac. Navigating Health Connect. I think one of the issue right now is the documentation of pressure injury. For continuity of wound management, even if the patient gets discharged or when they go to another Kaiser, they develop the avatar. And so you can find the perform wound care orders now in avatar activity. So wound care orders with dressing change directions are now linked to a specific wound LDA and are visible from the avatar activity. You can now see the directions in the avatar and do not have to navigate away from the wound documentation. WCNs also use doc flow sheet to document wound care, which is visible by the avatar and flow sheet. Click the Perform Wound Care hyperlink to expand the order comments and see the dressing change instruction. Reminder that Wednesday is Wound Picture Day. Primary RN to attach a new photo to wound flow sheet raw. Follow treatment orders from the PER or from the EMR and from the wound care notes. Document treatments on wound flow sheet and use comment boxes necessary. So if you are not sure what category of wound product you are using, you can just make a comment what kind of the brand name of the product that you use. If, for example, you can find the Santil, you don't know what is the category of the Santil, which is an enzyme, you can just make a comment that you use the Santil as your treatment. But please document that you did the treatment under the treatment portion of the flow sheet. So microturning is an LMC protocol ideas, which is still we're developing this intervention of using microturning, especially in hemodynamically unstable patients for ICU patients. So the idea is to still do microshifting of the patient's weight for patients who are unstable to prevent them from developing pressure injury. So for critical care nurses, use wedges for 30 degrees repositioning consistently achieved for 1 hour. Ensure proper wedge placement. All right to use fluidized pillow for head or extremities. The goal is achieving a safe 30 degrees lateral turn. Keep head of bed 30 degrees or less. Sacral pressures have been found to increase significantly when the head of bed was elevated 30 degrees or higher. At a minimum, the patient should be manually turned to gauge response at least every 8 hours after being deemed too hemodynamically unstable for positioning. Include low angle turning based on tolerance, weight shifting, passive range of motion, changing the position of the extremities, head rotation, and heel floating. Use continuous lateral rotation therapy on a specialty bed. And watch for the patient's response. Document repositioning attempt in body position comment box as needed correlated with vital signs. So this is the end of the presentation, and in behalf of the other wound care nurses, Melinda and John, we thank you for your participation for today's presentation.